Alright guys, let's get busy talking about hormone replacement therapy. We're going to be talking about estrogens and progestins, and there's a lot of complex physiology behind estrogens and progestins, and we talk a lot about this physiology in our content in chapter 2. So if you need a refresher on that physiology, go take a watch on some of those videos. In this video, we're going to largely be talking about indications for these two hormones, as well as some of their adverse effects. And I think the adverse effects of these two hormones in terms of administration for medical indication is where we have a lot of high yield points on the step 1 exam. So I really want to be focusing on that in our video today. So let's go ahead and get started by talking about estrogens. And just to refresh you, estrogen is going to be the hormone that is responsible for the proliferative phase of the menstrual cycle. So it's going to be here in this beginning part, and estrogen is going to be secreted by the developing follicle during this portion of the menstrual cycle. And when it comes to the mechanism of action, it's pretty simple. Our mechanism of action here is agonism at estrogen receptors. And in terms of the agents that classify as hormone replacement with estrogen, we have ethinyl estradiol, mestranol, and also diethylstilbestrol, which is known as DES. And DES is going to be a pretty high yield estrogen on exam day because it's associated with some specific side effects. Now, in terms of our indications, which is going to be a pretty important part of this video, we can use estrogens for menstrual abnormalities as well as ovarian failure. We can use it to help females who are suffering from hypogonadism, as well as menopausal hormone replacement. And then finally, we can use them as combined oral contraceptive pills. Oftentimes, estrogen is combined with progesterone to help with contraception. Now, in terms of our adverse effects, this is going to be where all the money points are in this video, and I really want you guys to tune in and focus here. So, one of the biggest side effects is going to be increased risk of thrombi, and this is because estrogen by nature is a prothrombotic hormone, so that's going to be one of the higher yield side effects to be aware of. Also, we can see postmenopausal bleeding in patients taking estrogen, and then clear cell adenocarcinoma is associated specifically with DES, which I told you is going to be a really high yield form of estrogen. And this is going to be a teratogenic form of estrogen because in mothers receiving DES therapy during pregnancy, their babies are more likely to develop vaginal clear cell carcinoma. So it's not necessarily the mother that's getting affected, but it's the teratogenic effect on the child who may go on to develop this type of cancer. Also, endometrial cancer can be caused by estrogen therapy, especially when this estrogen is unopposed by progesterone. Now, in terms of our contraindications for estrogen therapy, this really has to do with the prothrombotic effects of estrogen as well as the estrogen agonism effects at estrogen-sensitive tumors. So it's important to know that estrogen is prothrombotic, so you're going to want to avoid it in patients who are smoking at age greater than 35 because we know that smoking can increase the risk of things like DVTs and blood clots, and when combined with estrogen, this risk gets really, really high. So anyone with a smoking history or a DVT history, cardiovascular disease, we want to avoid supplemental estrogen therapy in these patients, and we also want to avoid it in estrogen receptor positive breast cancer because estrogen is going to increase the size of these breast tumors because they are sensitive and respond with growth when exposed to increasing levels of estrogen. These are the high yield contraindications when it comes to supplemental estrogen therapy. Now, let's move on to talk about our next hormone, which is going to be our progestins. And remember that progesterone is going to be the hormone that promotes pregnancy. So it comes in the second half of the menstrual cycle after ovulation. It's demonstrated by this purple line here. So when our follicle bursts open and it releases the egg, we are then going to have development of the corpus luteum, and that's basically the decaying remnant of the follicle, and it's this yellow body here, and it produces progesterone, which is responsible for the secretory phase of the menstrual cycle, and that's when we have increased vascularization and secretory activity in the endometrium. And so let's talk about the mechanism of action here. It's pretty simple. When we give exogenous progesterone, we're going to have agonism at progestin receptors, and remember that progestin is pro-gestation. It's preparing for pregnancy. So we're going to have decrease in endometrial growth because we already did all the growth when we had estrogen in the first portion of the menstrual cycle. And then we're going to have increased endometrial vascularization because we're preparing for implantation. And we're also going to have increased cervical mucus thickening. And this is because the body is like, no more sperm in this uterus. We've already been fertilized. And so it's blocking any more sperm from entering through the cervix. Now, in terms of our agents, we have levonorgestrel, medroxyprogesterone, etonogestrel, norethindrone, and megestrol. And these are going to be the progestins that you need to know for test day. These are going to be given exogenously. Most of the time, it's going to be in the form of a pill when it comes to history. However, there are a lot of different ways to give it. We can give it in terms of a subdermal implant and a depot injection, as well as an IUD. So it's important to recognize in history that they may talk about a patient who's presenting for contraception, and they may mention that they have a different form. All the forms are delivering the same chemical. It's just patient preference for how they wish to receive their progestin. Now, in terms of indications, we can use it for contraception. We can also use it for endometrial cancer because it is going to oppose the estrogen activity, which makes the endometrium grow. So this is a really helpful therapy for patients with endometrial cancer. We can also use it to treat abnormal uterine bleeding. Lastly, I want to talk about the progestin challenge. And the progestin challenge is going to be a diagnostic use of progesterone that we can use to evaluate patients with amenorrhea or lack of normal menstrual bleeding. And so if we have a patient with amenorrhea, we can do a progestin challenge, which involves giving them a large bolus of progesterone, and then we withdraw the progesterone, we stop giving them the progesterone, and then we expect one of two things to happen. What's going to happen is we're either going to see bleeding or lack of bleeding. And just to review, we're giving this bolus of progesterone to mimic this natural surge in progesterone that happens after ovulation. And then after we withdraw this progesterone, it mimics that natural decrease in progesterone that we see at the end of the menstrual cycle. And so two things are going to happen. We're going to see bleeding or non-bleeding. And if we see bleeding, this is amenorrhea due to anovulation. And this makes sense because if we never have ovulation, we're going to have this consistent high peak of estrogen, and we're not going to have that corpus luteum formation. We're not going to have that big bolus of progesterone. And so if we can give that bolus of progesterone artificially and then withdraw it, we're going to get normal bleeding. And this is as opposed to our lack of bleeding, which is going to be to hypoestrogenism. So if we never have high enough levels of estrogen, we're never going to grow an endometrium. So even if you give a bolus of progesterone and withdraw it, there's really going to be nothing to slough off. And so this is why these patients don't bleed. Also, we can have anatomic defects like Asherman syndrome, which is essentially scarring of the endometrium. And if you have an endometrium that's scarred, no matter if you give estrogen or progesterone, it's not going to grow appropriately. And if it can't grow appropriately, it's not going to slough appropriately, so we're not going to have bleeding. And then finally, we have chronic anovulation without estrogen. And this means you're not ovulating, but you're also not producing enough estrogen. So if you don't have estrogen, you can't grow an endometrial lining. So even if you give a big bolus of progesterone, there's going to be nothing to slough off. So I just like to think of the progestin challenge as saying, here's a big bolus of progesterone, we're going to withdraw it. If you have an endometrium to slough, you should be able to slough it, and that's when we expect to see bleeding. So it's important to understand the physiology of this because it's something I like to ask about on test day. And then also it's important to understand the contraindications for estrogen. That's going to be the two most high yield things in this video that I want you guys to focus on in your studying. I hope you enjoyed this one. Can't wait to see you guys in the next video. Bye!